To welcome you to day 2 of the 50th Golden Jubilee Icon Conference. Without wasting any further time, we'll start with the lung session. It gives me great pleasure to introduce our session coordinator, Dr. Nikhil Gadial Patil, who is also the program director of the conference. Over to you, sir.
Good morning, early birds. Thank you for being here on time. And today we have a very interesting day ahead of us where we are going to discuss more about lung and GI in this particular hall. And we had quite a good set of faculty who have traveled all over from India. I would say more than almost 250 faculty, and that's quite a good number. And almost all the faculties are quite renowned in their field, and that is what we are all looking forward to listen to them for today's and tomorrow's sessions. So without further ado, we'll start this first session for the day, and it is by Dr. Vivek Agarwala. Over to you. Yeah.
Good morning, everyone, and at the outset, many thanks to the organizers for having me here. So I have to start with the question that perioperative approaches to immuno-oncology in non-small cell lung cancer, whether we should go for neoadjuvant, adjuvant, or both. So when we look at the outcomes in resectable non-small cell lung cancer, 30% of the patients are going to be resectable. So 30% is quite a huge number of patients looking at the incidence of NSCLC. But when you look at the outcomes, in stage 1B, we cure 55% of patients. In stage 2, we cure nearly 40%, 60% of the patients. And in stage 3, we cure only 25% of patients. So 25%, 40%, 55%. Well, the outcomes are far from what we should be in this current era of targeted drugs, in the current era of immunotherapy. So when you look at the age-old chemotherapy, there were a number of trials that did not show a good outcome. Some showed positive, some showed negative, and the seminal LACE meta-analysis showed us that there was a 5.4% DFS benefit with adjuvant chemotherapy, which translated into a 5.8% overall survival benefit. And stage-wise, if we look, then the benefit was maximum in stage 3, where there was a 13% improvement in overall survival as compared to 10% in stage 2 and only 3% in stage 1. If you look at the neoadjuvant approach, well, in my institute, if I tell my CTVS surgeon that it's an N2 disease and I have to give neoadjuvant chemotherapy, he will not agree. And when you look at the data and tell him that there is only a 5% improvement in overall survival, and there is no difference whether we give neoadjuvant or adjuvant as per this study. There is no added benefit with the neoadjuvant, and there is a 9 to 10% risk of progressive disease. Then there is hardly I can debate him when he say that I can resect the mediastinal nodes. I have to go for upfront surgery. What about utilization of treatment? And when we see that in surgery, how many patients are actually given chemotherapy, we realize that probably only 40% of patients are able to take the neoadjuvant chemotherapy, which tells that probably if we rely only on chemotherapy, it is not the way to go. And in the current era, if not chemotherapy, then what we should utilize in lung is immunotherapy, and that is what we should look into. So what is the rationale behind using immunotherapy in early stage? Well, when we look at a neoadjuvant setting, there is a large mass sitting there, and this mass is likely to be not having any clonal resistance because there is no metastasis and there is a high neoantigen burden. So immunotherapy is probably going to act very well. And in the adjuvant setting, well, the anti-tumor immunity, which is actually gone because of the micro metastases which are resistant, the immunotherapy probably is the strategy that can actually restore this immunity. So there are biological rationales also for using immunotherapy in early stage. So when we look at the evolving landscape of studies in the early stage, when you talk about neoadjuvant, we'll discuss about the checkmate 816. When we talk about adjuvant, we'll discuss about the checkmate 091 of Pearls and the IM power 1010. And when we talk about perioperative, that is both neoadjuvant surgery followed by adjuvant, we'll discuss again keynote 671 and checkmate 770 and Nadim 2. And because we don't have toripalimab and tislelizumab, I would want to skip much data about that. So let us look at neoadjuvant immunotherapy. And Nadim was the first study that gave us this proof of concept. Very small study, 46 patients, 3 cycles of paclitaxel plus carboplatin AUC6, mind the dose, with nivolumab 360 milligram every 3 weekly. And in the surgery, all patients went for surgery and there was 63% pathological complete response. This is unprecedented responses. Small study size, maybe because of the higher carboplatin dose which was not used in the subsequent trials. But the 2-year PFS was 77%, 30% grade 3 adverse events, which is not so unexpected, but there was no deaths, delays in surgery. So clearly this same protocol moved to phase 3 with this checkmate 816 study, and there was a 3-year update last year. So this study included patients from stage 1B to stage 3, and patients were not having any EGFR ALK alterations and had a good PS, and the primary endpoint was pathological CR and event-free survival. Same dose was used, 3 cycles, and then they went for surgery within 6 weeks and followed by optional adjuvant treatment or follow-up. There was no adjuvant immunotherapy used. And this is the 3-year update. We can see clearly there was a 14% improvement in EFS at the end of 3 years with a significant hazard of 0.8. If you look at the subset analysis, I would want you to look into 2 things. What you see is that in stage 1B to stage 2, you see that the hazard is 0.94. There was hardly any benefit. But in stage 3, the hazard is 0.57. So the benefit was maximum and driven only through the stage 3 disease. And if you look the PDL1 subset, you see that as the PDL1 increased, the benefit increased, and in the maximum benefit was when the PDL1 is greater than 50%. What about path response? Well, not really what we saw in the Nadim study, but 24% patients had complete path response, obviously almost 12 times higher than the placebo arm. And what we understand already by the previous data is if you have path response, it is going to correlate with EFS and OS, and it is there. Toxicity was not higher in the treatment arm as compared to the placebo arm. And this is the 3-year overall survival of this study, and we see that there was a 14% improvement in overall survival with a hazard of 0.62. So we have an overall survival benefit also. Now let us look at the perioperative strategy. So perioperative strategy, again, Nadim 2 will start with nivolumab, which is again a small study of only 89 patients, and they included only the stage 3A and stage 3B patients. 3 cycles of neoadjuvant, what we discussed, and they used only 6 months of adjuvant nivolumab. So not really extensive treatment as the other treatment arms, and we see that 37% patients had path CR. Again, higher than what we saw in the checkmate 816, probably because smaller number of patients, but 37% path CRs. And we see that there was significant improvement in PFS and OS with a hazard of 0.47 and 0.43. Very significant benefits in both PFS and OS. What about checkmate 770? Now this is a larger study. This had 461 patients as against to the Nadim 2 study that we saw, which had only 89 patients. Here they used patients from stage 2A to stage 3B, and the primary endpoint was EFS. Same regimen they used in neoadjuvant for 4 cycles, surgery, and then after surgery they used maintenance nivolumab for up to 1 year. This was against the placebo plus chemotherapy treatment, and these are the results, and we see that there was a significant improvement in EFS with a hazard of 0.58, positive study, 20% improvement at 1.5 years. PathCR again improved by almost 5 times, 25% PathCR. And if you look at the EFS analysis subgroups, what you see that the benefit was marked in stage 3. In stage 2, the hazard is 0.81, stage 3, the hazard is 0.51. Again, N2 disease, the benefit was marked. Benefit was again more in PDL1 positive as against PDL1 negative, where the hazard was 0.73. Also, when you look at the left hand side, what you realize is 15% patient discontinued neoadjuvant treatment. Further 20% patients did not go ahead with surgery. 17% patient did not receive any adjuvant treatment, and 34% even discontinued the adjuvant nivolumab or adjuvant treatment, whatever was prescribed. So a significant number of patients did not comply well, and yet we have intention to treat EFS analysis, which shows a significant benefit. So what it says, as compared to the placebo arm, you look that there were the similar number of patients who had discontinued the treatment in the placebo arm also. So what we understand in real world, probably when we say that if we give neoadjuvant treatment, patients may not have surgery or may not be compliant to treatment or have more toxicity. The placebo arm has also equivalent numbers of patients which will have such toxicities. Aegean study with durvalumab, again very similar setting, 4 cycles of durvalumab plus chemotherapy followed by durvalumab maintenance up to 1 year, 2 weekly, same 2A to 3B patients. Primary endpoint was PCR and EFS. Again, significant EFS benefit, hazard was 0.68. And here also the benefit was more in PDL1 positive population, and in the higher stage again PathCR also improved. Keynote 671 with pembrolizumab, here also we see that 4 cycles of pembrolizumab with either a gem cisplatin or pem cisplatin, and nivolumab up to, again continued up to 1 year, same stage 2 to stage 3B patients. Primary endpoint was EFS and OS, and both the primary endpoint was significantly improved in the perioperative setting. When you look at the OS was not mature at 1.5 years, and we see the EFS data, again similar benefit in higher stage group, and more PDL1 the benefit is more, 50% there is higher benefit. And this is the updated overall survival analysis, and we can see that at the end of 4 years there is almost a 16% improvement in overall survival with a hazard of 0.72. So significant benefit. So if you summarize all the neoadjuvant and perioperative, what we understand that there is, all the studies are positive for EFS and for PathCR, and we have improved overall survival from the neoadjuvant studies, both Nadim 2 and Checkmate 816, as well as two of the perioperative studies. One is Keynote 671, we have the overall survival data also, and Neotorch from the toripalimab also we have the data. Now let us come to adjuvant immunotherapy. Again, there are 4 trials and 2 the results are there. That is the Keynote 091 or the Pearl study and the IMpower 010 study. Both the studies, they have included patients from 1B to stage 3A, and in 1B the magic number of 4 centimeter, what we understood from the LACE study. And the primary endpoint is DFS in the PDL1 positive population in atezolizumab, but the primary endpoint was DFS in the pembrolizumab irrespective of PDL1. Now, both the trials are positive, and if you look at side by side, IMpower 010, it had a very hierarchical statistical testing. They tested DFS in PDL1 positive in stage 2 to stage 3A. If it was positive, then DFS in all population, and then it was positive, then DFS in the OS in the all population. Whereas Pearls, it was very simple, DFS in all comers, irrespective of PDL1. And what is the primary endpoint analysis? Again, you see hazard was 0.66 positive in IMpower 010, but in the Pearl study, the hazard was 0.76. Again, positive improvement, but slightly lesser benefit. And look at the PDL1 subset analysis. So, when you see the improvement in PDL1, which was more than 50%, you see that the hazard is 0.43. So in IMpower, there was a great benefit in PD1 positive population, and when it is more than 50%, the hazard is again very high. But in the Keynote 091, when you look at the PDL1, you see that in PDL1, 1 to 49%, the hazard is 0.57. But when the PDL1 is more than 50%, the hazard becomes 0.82, which is something baffling, that why Keytruda in this strategy is not having good benefit. And this really raises some suspicion, some data manipulating, I don't know what, which is not correlating. I'm not able to understand why this happened. They are saying probably because there were lesser number of patients, but there were 117 patients. So it was a good significant number of patients. When you look at the DFS in the stage 2 to stage 3, this is what I was saying, that there was significant improvement when the PDL1 was positive. And when you look at the overall survival, so in the PDL1 more than 50%, there was a significant OS benefit with hazard 0.42, whereas OS benefit was not there in the adjuvant treatment in other arms, whereas in the Pearl study there was no overall survival benefit. So what we can summarize here is that both the trials are positive, but when you talk about PDL1 positivity, then atezolizumab comes in. But when you give patients irrespective of PDL1, probably you can give Keynote 091, EMA has approved, but the approval indications for atezolizumab are different. For FDA, they are giving in any PDL1 positive, whereas in EMA they have given approval only when the PDL1 is more than 50%. I'm again baffled why EMA approved Keynote 091 but approved atezolizumab only when the PDL1 is more than 50%. So again, after discussing all this data, the question, $1 million question comes, what should we use, neoadjuvant or adjuvant? And what we understand is that when you look at the neoadjuvant trials, there are lower pneumonectomies, so lesser surgeries. Compliance is good, more than 90% in most of the studies. PCR correlates with OFS and OS. You have a tumor downstaging, and there is opportunity for prognostication. You know what is the pre-treatment biopsy, what is the post-treatment biopsy. But 15 to 20% patients in all the trials, they are not receiving curative surgery. How do you counter that? Well, the number is similar when you are not using neoadjuvant, you are using only chemotherapy, also when you are not using immunotherapy. Again, there are no predictive biomarkers. PDL1, I think, have shown clearly is that there is a correlation with PDL1, and more is the PDL1, more is the benefit. So there is predictive biomarker. Again, no clear role in stage 1B and stage 2. I agree that these are the patients we should carefully select. And delay surgery in IO toxicity. Well, in chemotoxicity also this can happen and surgery may be delayed. And if you are talking about stage 3 patients, they are anyways going to be not operable. So if they are not undergoing surgery and later they are undergoing chemoradiation, probably this is justified. And when we are including these patients also in the study, we know that there is OS benefits, there are EFS benefits. Again, when you talk about adjuvant treatment, we see that there is no delay to curative surgery. So yes, operable patients, stage 1, stage 2, should we give neoadjuvant? Well, there is a big question, and I think we should go for adjuvant treatment. And there is survival benefit when the PDL1 is more than 50%. So we have option of selecting our patients for adjuvant treatment. Yes, the compliance to adjuvant treatment may not be good, benefit may depend upon different things, but this is the data and this is how we have to interpret them. What about patients who can't undergo surgery? So 20% patients have not undergone surgery, but in the Checkmate 816, when you look at this data, you see that patients who underwent surgery and patients who did not undergo surgery, both of them had a EFS benefit. So even if the patients are not able to undergo surgery, they are still benefiting from the patients in the placebo arm. So that is why you still can offer neoadjuvant treatment. Also, what you see is that whether perioperative is better than neoadjuvant. So the overall survival indirect analysis does not show any difference, but yes, in stage 3 we know that it predicts more survival, and perioperative may be a better. The question that whether after offering neoadjuvant should you offer adjuvant also. So there was analysis in the Keynote as well as the Checkmate 816 study, and it showed that patients who received adjuvant versus the patient who did not receive adjuvant, both had benefit. And patients who received PCR as well as patients who did not had PCR, both these patients had benefit with the treatment. So I think, probably when we talk about PCR is more prognostic than predictive in the current era. Again, how to avoid over-treatment, and then in the current era, I'll take just 1 minute more. We are all talking about MRD, we are all talking about ctDNA. And we know that there is a very good correlation between ctDNA positivity and recurrence. And ideally in a patient where ctDNA is negative or the MRD is negative, probably we are doing nothing if we are giving more treatment. So this may be one of the situations. And if you look at the IMpower 1010 study, you see that probably the ctDNA was found to be strongly prognostic in both the arms. And atezolizumab was showing benefit in both ctDNA positive population as well as the negative population. So ctDNA is prognostic, that we know, but whether it is predictive or not, this is something we don't know, and will require this sort of a study where you give neoadjuvant only when the ctDNA is positive, but if it is negative, you go for upfront surgery. And in the post-operative setting, the ctDNA is positive, then only you give adjuvant. If it is negative, you don't give. And if the ctDNA pops up later, even in the negative arm, you give the adjuvant then. Whereas in the adjuvant arm, if the ctDNA is positive, even after adjuvant, you change your adjuvant treatment. This is some sort of a study probably we are looking into in the future, which will, answer these questions. So when you talk about who is winning the race and what is the key messages, what I understand is MDT is the key when you decide to take on patients. When it is stage 1B to stage 2 disease and they are resectable in the MDT, preferably we should go for upfront surgery. But if there is delay in surgery due to any reason, in large institutions, heavy volume, late surgery dates, we should utilize the neoadjuvant IO plus chemo. And when these patients are resected, whether they received or not, in the adjuvant setting, if they are PD-L1 negative, if there are logistic issues, you may avoid IO. But if patients are keen, you can use Keytruda in a PD-L1 negative population. But if they are PD-L1 positive, the atezolizumab data looks much better, and I would want to start atezolizumab and not Keytruda in my patients on adjuvant setting. What about new patients who had received neoadjuvant IO and chemo? For all stage 3 patients, I think we should all offer neoadjuvant IO plus chemo. Even before we offer patients radical CTRT, because some of these patients may go for surgery now, and my preference looks to be 3 cycles, not 4 cycles, and Nivo looks to be better with the greater amount of data, larger number of trials. And after neoadjuvant IO plus chemo, if logistic issues are there, I may avoid further adjuvant immunotherapy. But currently, if there are no logistic issues, perioperative or the adjuvant is for all, and in future we may select our patients based on PD-L1, PCR and ctDNA. And what is the duration? Probably 6 months is the current duration. With this, I thank you all, and it was really nice to talk. Thank you. Yeah, good morning,
Sorry,
sir.
good morning. Very nice presentation, Vivek, as always. One question, one of your takeaways, you said PCR is correlating with OS and EFS.
Yes, sir.
Right? So assuming if an IO data where the EFS and OS is not mature, but the initial PCR data, the delta is more than 10%. Should we change our practice based only on PCR? That is one question. And the second one is, amongst all the trials what you presented, I think stage 2 and 3, if you have to go by, nivolumab data is not only good, but it is India conducive, because all you need to do is give neoadjuvant IO. And you may, if the R0 resection is there, you avoid IO and you get very good results. In fact, better than these adjuvant, atezo and Pearl study also.
Yeah, so I think, sir, for the first question, what you said, I think we have changed our practice in breast also based on PCR, and there is a strong data, and all the trials have replicated this thing that if the PCR is high, it is correlating with EFS and OS. Not only one trial, all the trials. So I think if we are changing our practice in lung based on PCR, probably we are going to be doing right for our patients.
So
in
you
most
would change your practice,
yes,
even
I think
before the data is mature for EFS and OS.
We can change, but then Now we have options where data is matured, so we can use that instead of a trial where data is not mature. And for the second questions, what I would want to say is that if you look at all these studies and see what was the difference between the European patients and the Asian patients, you also notice that the subgroup analysis shows that benefit is good in Asian patients also in some of the studies. So that also tells that yes, the data is good for the Asian patients and Indian patients. And regarding only giving 3 cycles, I think this is like a must. We
That's
should
what I
use,
say.
especially in stage 3 patients. We should counsel all our patients to receive at least 3 cycles of neoadjuvant nivolumab, whether they can go for adjuvant or not.
So I just wanted to have some comments on this. First of all, I don't think so we'll ever have a head-to-head trial of neoadjuvant versus adjuvant or neoadjuvant versus perioperative. So probably we'll never know the answer. But if you see how the systems are evolving in other tumors, and if you see how it is evolving in an adjuvant setup in lung cancer, then probably you realize that the CheckMate 816 trial has done a favor on most of us by coming first. If you see in breast cancer in adjuvant, the first trial of adjuvant trastuzumab was 2 years versus 1 year. And because of that trial, all the other things, data that is coming up, 6 months trastuzumab, 3 months trastuzumab, is only doing catching up. And there is no end to this. If you see, I think few days back in ESMO in sarcoma, the GIST, they have showed that 6 years of adjuvant imatinib is better than 3 years. So in lung, because the CheckMate 816 of 3 cycle only has come first, now the others have to show that they're better rather than what has happened in lung setting or in adjuvant sarcoma setting. And the last point is that in breast cancer, suppose we give neoadjuvant chemo and we don't get PCR, we change the drug. We go to TDM1. In a neoadjuvant IO, if you give 3 cycles or 4 cycles and there is no PCR, what is the logic in giving the same IO or a different IO? Ideally, you require an ADC. So this is how probably the future will occur, that you give neoadjuvant IO, and if there is no PCR, there is a residual disease, you change to ADC, the way it has happened in breast cancer with neoadjuvant trastuzumab and the TDM1.
I think, sir, for the stage of disease, I think that will matter, sir, because you want to also understand whether the PCR mostly happened in stage 2 diseases or whether it happened in stage 3 diseases. That data is not out yet.
Yes.
So we need to look at that. But in stage 3, I will say that we all should give neoadjuvant IO. This is one thing. And second point, sir, is that when you look at the PCR data, well, the benefit is both in patients who received PCR or not PCR. So neoadjuvant at least we should give. Adjuvant, whether we should give or not, I think this is something that we need to see.
Neoadjuvant is clear cut.
In the neoadjuvant, there is an OS benefit. And in the perioperative, the trials are yet to mature and show OS benefit. So I think if today I say that I will give only neoadjuvant and I'll wait for the data to mature and see comparative OS, I think it makes sense, sir, today.
Fine.
Thanks Vivek, and thank you, Amol. Now you have taken 2 minutes of your debate. Let me invite you for the next debate, which is on combination therapies in EGFR mutated non-small cell lung cancer. And we have 2 excellent debaters over here, and debater who is going to talk in favor of single agent TKI is Dr. Amol, and countering him will be Dr. Udip.
So thank you organizers for giving me an opportunity to have an interaction with you all. And I'm going to speak, of course, for no. I have no conflict of interest to declare. Probably AZ cannot afford me. I don't know what is AZ. You are free to guess. The discussion is done with the assumption that there is no cost constraints and all drugs are freely available, as Dr. Senthil said. Let us start the discussion assuming that the cost of the drug is 1 rupee. I'm not saying again 100 rupee because 100 rupee is not got ill-famous in last few weeks. So discussion is for the first line of treatment of advanced NSCLC with EGFR mutation and for trials for which phase 3 data is available. So if you see options available for first line treatment of EGFR positive non-small cell lung cancers are 3, OC mono, OC plus chemo and AMI plus laser. But if you see the PFS data, the OC in original trial was 18.9 months, and for whatever peculiar reasons, the same OC data has reduced to 16.7 and 16.6 in the subsequent trials, and we all know how these things happen, that from one trial to another trial the data changes. So when you evaluate combination therapy, what we ask, does the combination treatment improve survival? We are talking about metastatic lung cancer, where we all know the survival is not great, and we have to look at the overall survival, and does this leads to more toxicity? And based upon these questions, we need to evaluate the combination therapy. There has to be a benefit of the combination, and as he has shown, the benefit can be anything. But what we need to have is a meaningful benefit. There is no point in having what is called as opportunistic combinations. We have to have a meaningful combinations. And when osimertinib plus chemo came, there was a hell lot of uproar on Twitter, and Vinay Prasad, as quite a few of you must be knowing, that a lot of people have lamented the FDA's decision of giving approval based upon the FLURA trial, and let us see why this has happened. Everybody will say, damn, it improves PFS. And let us first talk about those without CNS metastasis, and let me point your attention to the hazard ratio confidence interval. It has crossed unity. So without CNS metastasis, the PFS has gone above 1, and we all know when it goes above 1, there are some patients in which it is detrimental or it has caused harmful effects. So it is not honky-donkey in those without CNS mets. Let us come to the CNS metastasis later. It is twice more toxic. 24% patients in a clinical trial done by an MNC could not complete even 4 cycles of chemo. If this is happening in a clinical trial, can you imagine what will happen in a real world setup, especially in a country like India? It is very difficult. How many are able to complete the chemo? 75% discontinued pemetrexed maintenance. We all say that, oh, it is easy to give, we are medical oncology, we are supposed to manage the side effects, but pemetrexed is not a great drug. It causes a lot of mucosal side effects, mucositis, diarrhea, neutropenia. So in that clinical trial, 75% patient discontinued pemetrexed maintenance. So it is very difficult to add on chemo and complete that chemo. Now let us see post-progression therapy. Again, it is not perfect. We all know these are the secrets of the trial, and only 81 patients out of 278 on OCM got chemo. When in a clinical trial, your post-progression treatment are not in a perfect balance, we all know what happens with the curves and how they get manipulated. But what about the PFS2 and OS? Of course, the OS is immature, it is at present, the hazard ratio is crossing way above 1. But if you look at the PFS2 and if you look at the difference in PFS1 and PFS2, the curves are narrowing down. In spite of an imbalance in the post-progression therapy, the curves are narrowing down and the difference is reducing. So probably it is not a great strategy to combine, but as everybody says, what about those with the brain metastasis? So let me show you how they have analyzed those for the brain metastasis in this particular trial. There is something called as a CNS full analysis set, in which there are patients with more than one measurable, that is more than 1 centimeter, and non-measurable CNS lesions at the baselines, and other is CNS evaluable for response set when patients with more than one measurable CNS lesion. They have not taken non-measurable in that particular set, and they have done MRI only in those patients who have baseline CNS metastasis, but not in a CNS metastasis, not with those who do not have baseline CNS mets. And I will tell you the significance of this in the next trial. Now, if you see patients with CNS lesion, more than 4 lesions, almost 29, 26 patients in each arm. What we do currently, I don't know whether the radiation oncologist in the audience, we give radiotherapy. There are superb techniques of radiation coming up, SBRT, and if there are fans of proton therapy, there are proton therapy coming up, and the side effects are not that great. But if you see this, hardly any patient have received in this particular trial, even though they have 3 lesions, 4 lesions, hardly any patients have received radiotherapy. Why this bias? What about radiotherapy? Can radiotherapy compensate for your chemo? And probably the answer is yes. This is not what we do in the real world practice. And now let us come to the full set analysis. And if you see the full set analysis of the complete evaluation, that means measurable, non-measurable disease, the EFS, the response rate difference is hardly 13-15%. 59% versus 43%, so not a great response. It's not twice the response or doubling of the response rate. And if you see, the toxicity is maximum in the first 4 cycles or 5 cycles. So patients with brain mets, they are not easy to give chemotherapy. Top of that, you are not giving them the radiation. And top of that, my response rate difference is not great. So why should I go for a combination? And important question, this was asked in NEGM in letters to the PI, in which they asked, is this upfront chemo versus sequential chemo answered by this trial? Answer is no. And please note what I have highlighted. The PI of the trial himself has said that this particular trial was not designed to assess whether you can give it concurrently or sequential. So they all know, you see, it's the tricks of the game, and everybody knows that trials are designed in such a way that we don't get all the answers, or we get only answers that we wanted to have. Now let's come to the Mariposa trial. As I've shown, what they have done, I think the slide is not that clear, but they have done the MRI evaluation in all patients, whether they have baseline CNS mets or do not have baseline CNS mets. And that is a good way of doing things when you're looking at the stage 4 metastatic lung cancer. It has shown PFS benefit, but again, if you see, there is no OS with Mariposa also. There is, in fact, more toxicity if you give the combination. So this is again a survey which has published in NEGM, and they have asked what patients want. So most of the patients, if you see in this particular survey, which is done in non-Indian patients, of course Indian patients will go for oral TKI only, in them also they have asked for oral TKIs. And last slide, if you see, is a cross-trial comparison, and if you see, based upon the PFS, what is the comparison of Flura to Mariposa? There is hardly any difference. So if I do not have much of an OS benefit, I have a lot of toxicity, not at all much of PFS benefit also, what I will like to do, ideally this kind of a trial, I start with osimertinib, I assess the ctDNA, if there is a residual disease, then I step up, rather than everybody giving everything at the day one. That's what I feel. So what is the role of combination therapy in first-line therapy metastatic NSCLC EGFR mutation? When there is no OS benefit, when there is excess toxicity, whole lot less than always, marginally more than never. Probably in some few patients I may end up giving it, but for all practical purpose, it is the single agent that should be the take home. Thank you.
Yeah, Amol, can you take a chair over there? And may I request Dr. Udip to take his position against the combative Amol. Amol, as usual, is in his elements. Take it up.
Yeah, so thanks Icon for inviting me to Hyderabad, and my topic for today would be countering the great man. So oral TKI plus chemotherapy in EGFR mutants. Speaking for the topic, so as we all know that lung cancer, we have a lot of mutation testing, and molecular testing is the way forward, and personalized or personalized therapies have taken a front seat. And as with Dr. Amol's talk, osimertinib's towering presence has led to single agent TKI as the mainstay of lung cancer right now. But however, ye dil mange more, right? So we need more. And yeah, so let's look at the shortcomings and limitations of a single agent TKI. And if you see, oral TKIs have overall response rates of up to 80%, but all these years, first generation TKIs have had good response rates, and progression, the duration of response is limited, and the progression is usually inevitable. And if you see the trials that have happened with first generation TKIs, single agent TKIs did improve the PFS but did not improve the OS. And there is a meta-analysis which also proves that OS was not improved. However, we still continue to use gefitinib as the mainstay, afatinib as the mainstay, still without an OS benefit, right? So going next, differential response to L858R and DEL19 was highlighted in the tumor mutations. So we don't know which tumors are responding better to a single agent TKI. Next is strategies to improve, and this paper shows the same, the Lux Lung trial. Next, development of resistance to EGFR in the EGFR dependent and independent pathways is something which we need to look forward. Are we, with using a combination, delaying those resistance happening, or even preventing those resistance from happening is something that we need to look. Post-primary TKI failure, tailored therapy is required, and chemotherapy may not necessarily provide better results. So there are trials where they have seen post-osimertinib resistance, and they have seen that in the most common mutation, that is C7S, we do have a combination of cetuximab plus brigatinib giving ORRs of 70% versus a chemotherapy which gives an overall response rate of 10%, just 10%, and a PFS of 3 months. So it may not be sure that second line chemotherapy will work in these patients. And in fact, a molecularly targeted or a precision oncology approach will better work in these patients, right? So close to 40 to 50% are unable to take second line chemotherapy. In most of the trials done by TMH, by by Dr. Narona and other trials show that 30 to 40% of the patients post single agent TKI failure are unable to take the second line chemotherapy. Are you going to miss such young patients where we don't give them the benefit of chemotherapy? So shown by the paper here, quoted here as by Dr. Narona et al. And advantages of, so coming to the advantages of combination chemotherapy, it's been shown by 3 or 4 trials which are phase 3 study, and that is the GAP-brain trial by Hu et al. Second is Gefitinib plus Gef versus Gef plus PEM by TMH paper. The third is the NEJ009, which has shown OS of 50 months, which is fantastic. We've never heard of 50 months OS in lung cancer, right? And FLORA-2 trial, osimertinib plus this, which is the latest publication. So better ORRs, as we see, Gef plus chemo. The ORRs are 80 versus 64, 75 versus 63, 84 versus 67, grossly improved. And we are not looking at doubling of ORRs here, right? Every 10% is a benefit for that particular patient. So better PFS, GAP-brain trial has shown a PFS advantage, 15.1 versus 9.1. TMH has again showed 16 versus 8. NEJ009 has shown 20.9 versus 11.9. And an HR of 0.49, which is tremendous. And this NEJ paper forms the basis where Gef plus chemo can be used as a poor man's osimertinib. However, now with the FLORA-2 trial, we have data that osimertinib plus chemotherapy also does better. So osimertinib in the FLORA-2 trial shows 25.5 months versus 16.7 months. Yes, the OS from FLORA-1, FLORA-2 is different for single agent arm. But yes, we can contemplate or assume that the trials have some manipulation, but we don't know for sure, right? So better OS in Gefitinib plus chemo arm versus Gefitinib, the NEJ009 trial, which is the last one I've listed, 50.9 months versus 38.8 months, HR of 0.72 is quite significant. You can't ignore these particular data set. TMH trial also not reached versus 17 months, and the GAP-brain trial also showed a 35 months versus 28.9 months with a OS advantage, 0.04 p-value. So OS advantage is there, we just need to look. Better CNS response rates, I agree, but I don't know how many of us with the osimertinib now are giving radiation to a non-symptomatic brain met. I for once am not giving radiation to them. Intracranial responses are 85% versus 63% with a p-value of 0.002, and that shows the difference. And the response rates are, I think, 20% more, which is a significant number, right? From 63 to double, it will be 120%. I don't think we can achieve that number. So 2 key points, again, is chemotherapy, better results in chemotherapy plus Gef-TAM despite the patients receiving second line therapy. Patients did receive second line therapy, but still there was a definite advantage. Hu et al. Paper, 95% in the Gef-TAM received second line chemotherapy, including 71% who received a platinum doublet, and still there was a OS advantage. So are we preventing that mutation from happening or a resistant mutations from happening in the earlier? Because both of them are getting sequential therapies and still there is a advantage in the first line use of combination. So limitations of this, obviously, as Dr. Amol also highlighted, the toxicities are more. We'll need to better select our patients. It's almost doubling of toxicities, as he mentioned. And even the serious side effects that were seen in FLORA trial were 19% versus 5%, for which it is criticized also. So I agree that, to conclude, that in the era of drones, in warfare, let's not forget the tanks of oncology. So chemotherapy is the tank and still remains the tank. We should use it wherever possible. Lastly, we would have to choose the right patient for the right therapy. And as we have, the options, a 5-seater or a 7-seater car, which will commute from point A to B, there will be takers for all of these. We'll have to select our patients for the right thing. A young patient deserves a chemo plus OC combination so as to attain a good survival. Hopefully we see a survival benefit in this. I would conclude my debate with a saying, a journey of 1,000 miles begins with a single step. Thank you.
Thank you, Udip, for your thoughts. And how about your slides that you like more? So thank you, Udip, for your excellent points. And I saw from your slides that you like more. You saw 3 girls, 4 cars. But there are some people like me, followers of Lord Rama. They believe only one Pushpak Viman and one. Yeah. So when you have one effective Pushpak Viman, you don't require cars. So, and the second point is that I told in my first slide in disclaimer, cost is not a discussion here. If we're talking science, and then Jeftanib plus chemo is gone by era, we are straight away, everybody knows that a patient is affording, we start with osimertinib. So let us talk about osimertinib plus chemo, if at all we want to discuss, or osimertinib plus anything else, if you want to talk about combination. And that is too toxic. In a clinical trial, if this much of toxicity is going to occur, then it is in real world, it is bound to be more toxic. And the last thing, why a cranial radiation is not given for a patient with 4 or more than 4. We don't know, more than 4 can be 6, 7, 8. So much of brain mets, you don't end up giving radiation. Generally, most of us will not do that. We don't wait for patients to have symptoms. And ideally, there should be a trial of OC plus chemo versus OC plus radiation. And I don't know whether there is any radiation oncologist in the audience. I was hoping somebody will be there to back me. But this is what we should look at. And with good technologies of radiation, maybe we can get rid of the chemo, especially in those with the brain mets. Anything else? So follow the Lord Ram, please.
Udip, anything from your side? Last word. And over to then Dr. Chirag.
I tend to, see, it's a debate, but I would also tend to agree that there are toxicities that are associated with osimertinib plus chemotherapy arm, but there will be certain patients who will benefit from this, and we should not outrightly reject osimertinib plus chemo, and this is how research progresses, and probably next 2 years we'll be debating, I think Dr. Amol after 2 years may be debating for the same topic, that we should go for chemo plus osimertinib. Let's wait for data to mature. I think it's going to be the way forward.
So that's it. No secondary rebuttal. So both of the debaters have done the wonderful job, and it's going to be a tough time for me to have the final comment. But what I will want to say is that we have come a long way in the management of lung cancer in general, and EGFR positive lung cancer in particular. Before about 3 decades, whether to treat the patient with metastatic NSCLC or not, that also was a question. And now with gefitinib, we have seen that the survival is around 2+ years. With osimertinib, it is 3+ years. So the survival is improving, but we don't have so many lines to be given one after other in EGFR positive NSCLC. And in that case, if we look in general over the base trial design, it should look at overall survival and not PFS, right? So, Amol, as you said, that PFS advantage is demonstrated, but OS advantage is not yet demonstrated with combination. So that is the caveat of all the trials that he presented, right? But at the same time, not demonstrating the overall survival doesn't mean that the overall survival advantage is not there. The trials are not mature. So that's it. So if we should accept the combination in our practice or not, I mean, if that's a verdict which I am supposed to give, I would say that I will accept the combination, but I will be very careful in ensuring to select the right patient, and I will ensure that I am not giving unnecessary toxicity to my patients. So with that carefulness, that caveat, I think I am for a combination, but the single agent also is doing a great job. So that's my conclusion. Thank you very much.
Thank you, sir. Thank you.
Thank you both the debaters as well as Dr. Chirag. And we move on to the next
Dr. Nikhil, can I give a very rapid comment?
Yeah.
So a very fast and rapid comment. So now the treatment of lung cancer has so much evolved, we cannot say this one treatment is good for all the EGFR positive patient. This one treatment is good for all other patients. So we need to individualize the patients. For example, if you I quote my own data, EGFR exon 21 mutation patients with P53 mutation, median PFS is just 8 months. EGFR exon 21 with CDKN2A mutation, which comes frequently, the PFS is just 6 months with osimertinib alone. So we need to individualize, we need to find where to utilize. Combination always, never. Combination never, that is also never. So we need to individualize, that is what I will.
Yeah, I agree with you. Since that we live in the era of precision oncology,